Hi everyone. Today we're going to be covering endo, myo, and pericardial diseases. What we're going to do is really start from the inside layer here with the endocardium and work our way through to the outermost layer, the pericardium, and discuss basically the various factors that can irritate, damage, infect those layers, and ultimately the hemodynamic outcome of that and how that would be seen in the patient via their signs or symptoms, and then how we would treat that. So to start off, I'm going to start with infectious endocarditis. Infection of the endocardial surface of the heart. So just to kind of keep in mind that the endocardial surface of the heart, the innermost layer of the heart, is actually very similar to the endothelium lining the insides of the blood vessels. And in fact, it's continuous with it. And I also want to point out that over the valves, and you can kind of see the picture over here, which is opened up in the heart here, that the valve here, you see the chordae tendineae, the papillary muscles, that this valve actually has an endocardium or endothelial type cells surrounding it as well. And I really want to impress on you here that this infectious endocarditis is a very, very serious illness. In fact, the 6-month mortality is 20 to 25% with therapy. That means 1 out of every 4 or 5 people who come down with this, all right, can die even with appropriate therapy. Okay, it is 100% mortality rate without treatment, so it can be very, very deadly. And so you can see here in the picture with this valve, you can see the opening of the ventricle here, the atria, and you see the valve here, and it kind of has this yellowish color, and you can kind of see these little spots, these little yellow spots all over it, as well as some up here, as you can see. And that's showing you that we have some kind of a culture here, or growth of bacterium that has sort of seeded the valve and can ultimately cause its destruction, leading to things like heart failure and other such problems, which we'll talk about. The classification of infectious endocarditis is really kind of broken up into 3 parts, which you can see here in 1, 2, and 3. There's the clinical course, which is defined by whether or not this is an acute or a subacute endocarditis. Obviously, that's referring to the timing of it. So the acute would have very sort of sudden onset and would have very sort of fulminant features, which we'll talk about a little bit more. But importantly, usually one of the bacterium that causes an acute bacterial endocarditis is known as Staph aureus. That is the most common for an acute bacterial endocarditis. And in fact, another important feature of that is that Staph aureus in that acute setting can actually damage the valves on totally normal, healthy valves or normal endocardium. Now, in subacute, the bacterial endocarditis, most commonly known for that, is Strep viridans, which is a bacterium known to colonize the mouth and upper respiratory tract. And this is probably one of the most common causes of infectious endocarditis, and it's also the most common cause of infectious endocarditis on an already damaged endothelial surface or valvular surface. Now, I have to quickly point out here that the cause for subacute versus acute, they could be very similar. It's just a matter of the pathogen that actually gets into the blood and causes the bacteremia. And like I said, Staph aureus can damage already healthy valves, whereas a Strep viridans, it's really more likely to only affect those who have damaged endothelium or endocardial surfaces. And the most common cause of damage to that surface is going to be turbulent blood flow going through the valves, which ultimately disrupts the endothelial surface and causes a lot of the problems that we've talked about in prior lectures, where you have disruption, which leads to hypercoagulability at that location, thrombus formation, and of course, disruption of normal vasodilation or vasoconstricting effects. Now here, the host substrate is another way to classify it. And again, that has to do with whether or not the patient who's infected has a native valve or a prosthetic valve. The native valve is 60 to 80% of the patients who have infectious endocarditis. They all have native or valves that they were born with. The prosthetic valve, all right, is most commonly associated with infections of staph epidermis, and often results from the fact that the valve placement has caused disruption of the endothelial surface that has been maintained and makes it a higher risk for patients to come down with infective endocarditis. IV drug abuse is also thrown into this category. And again, IV drug abusers could have native valves as well, but the fact that they're intravenously using drugs means that the most common site for them for infectious endocarditis is usually on the tricuspid valve, so on the right side of the heart, whereas most commonly, in most of these other patients, it's going to be on the right side of the heart, usually the mitral or the aortic most of the time. The specific infecting organism is another way to classify it. That's number 3 here. The most responsible organisms are typically gram-positive cocci, like Staph aureus, or the streptococci, like the strep viridans that I mentioned earlier. They are the most resistant. They have a cell wall with proteins that allow them to bind to endothelial surfaces, as well as to the platelet surfaces when there's some sort of thrombotic material present. And they're also very resistant to things like complement in the bloodstream. So when they do get into the bloodstream, they manage to actually invade a lot of the white blood cells and are more likely to be able to seed or bind to, again, to that site because of the proteins in their surface. Now, in addition to the fact that most commonly they're gram-positives, they are also usually associated with anatomic sources. So remember, our body has normal flora and other bacteria that line our skin and our mouth, as well as our GI. And so, as an example, if the things lining the colon, right? So if somebody were to have, say, colon cancer and getting a biopsy done through a colonoscopy or something like that, Streptococcus bovis is located there and could cause bacteremia. And somebody who already has damaged endothelium could ultimately lead to infectious endocarditis, as well as like strep viridans, anything orally, causing disruption of the gingiva, like a tooth extraction or something of that nature, can cause something like strep viridans to get in, cause bacteremia, and ultimately seed the valves as well. So the pathogenesis of infectious endocarditis starts with typically endocardial surface injury. Now, I mentioned before that Staph aureus can actually seed the valves and the endocardial surface on normal, healthy endothelium, and that's sort of the exception to the rule. Generally speaking, if the patient has endocardial surface injury from, let's say, long-standing hypertension and some sort of regurgitant murmurs, something causing turbulent flow, they could have endocardial surface injury. And like we spoke about in prior lectures, that injury can ultimately lead to platelet activation and fibrin forming a thrombus at that site of injury. The problem with that is if the person happens to become bacteremic and they also have to have endocardial injury with thrombus formation, they're more at risk for having infectious endocarditis. And so ultimately the bacteria could adhere to that injured surface, and then they could grow and multiply and seed the valves or the inside of the heart. And again, it really relies on the fact that this bacterium has access to the bloodstream. It can survive in circulation because it's resistant to things like complement, like the gram-positive cocci, and of course being able to adhere. Strep viridans happens to have dextran, which is a protein that allows it to bind to things like platelet and injured endothelial cells, making it much easier for it to bind to those surfaces and then again multiply. In addition, once it does bind to that surface, this platelet fibrin thrombus that forms can actually create almost a protective layer over the surface of these growing bacterium and even further protect it from white blood cell intervention. So that you can end up having very, very large colonies growing and ultimately forming a very large thrombus, which is also containing bacterium. Create an abscess, which you can see right here. Okay, and that can be quite deadly. And again, this could happen in the brain. It could happen to the kidneys. It could seed the heart, the aorta. In addition, you have the white blood, your immune system fighting off this particular bacterium, and you end up with these antigen-antibody complexes known as a type 3 hypersensitivity. And one of the most common findings of that is glomerulonephritis, which can ultimately lead to kidney failure in these patients. So And my last bullet point there, epidemiology is evolving because more and more bacteria are actually becoming drug resistant in a lot of these hospitals, making this quite a challenging infection to try to treat. Some of the manifestations of infectious endocarditis, if it's acute, generally when it's acute, it happens more suddenly. And so the disease is more fulminant. So you have high fever, shaking chills. This patient usually looks very, very ill. And in subacute is more like a low-grade fever, non-specific sort of flu-like symptoms that ultimately may get passed off as something else, something maybe more viral. And however, these would usually persist for weeks. On examination, a couple things to kind of keep an eye on. So first off, on the cardiac exam, any new murmurs. So somebody's coming with high fevers and shaking chills, or in this case, low-grade fever or non-specific symptoms. If they have a new murmur, that's definitely a red flag, again, because they can erode through those valves. Old murmurs, because old murmurs create turbulent flow, which can damage the endocardium, which means they're a risk. And again, any sign of heart failure. And again, the signs of heart failure, this is the leading cause of death for infectious endocarditis. Ultimately because, especially in the acute state, when it damages the valve enough that you get a regurgitant murmur and you get overloads of volume on a heart that has not had time to compensate. Some other signs with septic embolism. So again, if some of this broke off and we're actually to seed other organs, or if we were to get, say, an immune complex deposition like that type 3 hypersensitivity that I was referring to earlier. If it happens in the brain, things like stroke or infarct, neurological findings could be quite diffuse depending on where. Kidney, flank pain, hematuria, renal failure, glomerulonephritis, which I mentioned before, lung, infarct, infection. Sometimes they may even present with like an pneumonia. Now, again, with the lung, kind of keep in mind that to see that sort of what looks like kind of a PE or a pneumonia means that the right side of the heart was probably seeded, like the tricuspid valve, for instance. Vascular aneurysms, we could have a mycotic aneurysm. So now a mycotic means this is caused by an infectious agent. And if you recall the vasa vasorum, which actually provides blood supply and nutrients to the larger arteries like the aorta, for instance. And if you get emboli in those vasa vasorum, you're essentially depriving the aorta of nutrients and supply there, and it can cause weakening of the wall, as well as inflammatory response due to the bacterium, and this can lead to an aneurysm. In the skin, there's something we call peripheral stigmata, and these are things they really like to test on in standardized tests. So we have here petechiae, these little splinter hemorrhages you can see anywhere in your body. These splinter hemorrhages underneath the nail here, so you can see this right here. These are splinter hemorrhages, these sort of longitudinal black streaks you can see here, which are these little hemorrhages underneath the nail. Janeway lesions, so you can see that over here. These Janeway lesions, which can be on the fingers and toes, sometimes in between the toes or on the soles of the foot. And they kind of look like these sort of black flat spots here, and usually painless. The Osler nodes, which you can see over here, and the Osler nodes are these raised papillary lesions here with the sort of red center here, and the sort of pale ring. These are more painful, usually on the fingers, again, in between the fingers or toes. And then Roth spots. So if you take a look at the retina, you can actually see a hemorrhage here, which you can see this is the ring of the hemorrhage. At the center has sort of a pale region where essentially you had an embolus blocking that area, causing increased pressures. Diagnostic studies for infectious endocarditis. Again, patient comes in usually with a fever because they're bacteremic. Elevated white blood cells. Again, fighting off the infections, releasing inflammatory mediators. Again, that would cause the fever. Inflammatory markers like ESR and CRP would be elevated. The ECG. Now, there's no specific ECG finding for this. It really depends on what's happening to the heart. So, for instance, if it's sort of eroded into the conduction system, you might see a heart block, or you might see some other type of dysrhythmia. as well as maybe even an MI or something of that nature because it's eroding into the myocardium, causing damage and release of troponins. The echocardiography usually will visualize the vegetations, and the transthoracic is very good for seeing these vegetations, but what's more sensitive is actually the transesophageal. It's much better at picking up those vegetations. And you can see over here, here's actually a growing vegetation on the mitral valve. All right, so there's the left ventricle, here's the left atrium. And then again, the last part you want is the blood cultures. Now, this is important for diagnosis and treatment because when you get the blood cultures, first it can help diagnose what kind of bacteria is in the blood, and then ultimately what are its sensitivities, so that way you can guide the treatment. Now, this is important. Multiple cultures will be taken. So 2 to 3 cultures, and we use different venipuncture sites. We don't want to take them all from the same site for risk of contamination. And we usually know what bacteria will cause contaminations, and so would have low suspicion if it looks like something sort of contamination. So that's why we take multiple sites. And if it looks like these bacterium are the type of bacterium that typically cause infective endocarditis, like strep viridans or Staph aureus or something of that nature, okay, if we have multiple cultures that come back positive, all right, that would definitely lead to an indication for endocarditis. But understand that when we collect these cultures from different sites, we always collect them before initiating empiric antibiotics. So it's really important because you don't want to give antibiotics and then collect cultures because it could actually obviously give you a false negative. So the criteria we use for diagnosing infectious endocarditis, all right, is called the Duke's criteria. So we have this modified Duke's criteria. So if you look down here, the sort of Duke Blue Devil, little joke they're making here. All right, so here you have 2 major to make the diagnosis, 1 major, or 3 minor, or 5 minor. So the question is, what are they? So what are these criteria? Right here, Duke's major criteria, 2 positive blood cultures. So typically 2 out of 3 positive blood cultures, positive echo. And so the major criteria for those echo I have listed over here. So that could be an oscillating intracardiac mass, a myocardial abscess, a new partial detachment of a prosthetic valve. So it's important to kind of keep in mind, these are the major criteria on an echo. There'll be a whole bunch of other minor ones, which we're not going to get into right now. And then again, any new regurgitant murmur. So those are sort of your 3 major criteria. So any 2 of those, all right, will meet the Duke's criteria. The minor criteria are any kind of predisposing condition. So somebody who has a congenital heart disease, which puts them at risk for endocarditis, particularly the cyanotic heart diseases, any type of prosthetic valve replacement is a predisposing condition, or any type of prosthesis that's been used in the heart, even for congenital heart disease, for example. Fevers, immunological signs like glomerulonephritis, or any of the peripheral stigmata listed over here, like Janeway lesions, splinter hemorrhages, and so on. Only 1 positive culture, or a positive echo, but it doesn't meet the major criteria. So again, if you had all 5 of these signs here, that would meet the criteria, or at least 1 major and 3 of these minor. Treatment and prevention. So since this is such a deadly illness, it will require 4 to 6 weeks of a high-dose IV antibiotics. And again, obtain those cultures before starting. The empiric broad-spectrum antibiotics can be used initially, and you basically want to cover everything. You want staph, strep, enterococcus, gram-negatives. So you want to kind of cover everything because you can have gram-negatives. You can even have fungal infections like Candida. So you have to make sure you get broad range. And then when when the cultures come back and you know what the sensitivities are and what they're growing, you can become more specific. Surgical valve replacement in some cases. So if you're seeing hemodynamic compromise or damage to a valve, or a valve that was just recently replaced, or you see an abscess, those all have to have surgical intervention. Prevention. So there is a category of people who fall into the highest risk of infectious endocarditis with certain procedures. So I've listed some of the procedures over here, and these are the highest risk. So this is the American Heart Association recommendations. If somebody has a prosthetic heart valve, a history of infective endocarditis, congenital heart disease, again, typically the cyanotic ones or ones that have just recently, not recently, but at least have been repaired, as well as transplants with valve abnormalities. Okay, so they're your highest risk group. That doesn't mean other groups can't get it. It just means they're at lower risk. So of this high risk group, it is recommended to give prophylactic administration of antibiotics for these certain procedures, like dental procedures. Again, tooth extraction or something of that nature, where you could end up becoming bacteremic and have things like strep viridans, strep mutans, or the upper respiratory tract. Any kind of procedure involving that, particularly if it has biopsy of the mucosa or a tonsillectomy. Okay, those are higher risk for bacteremia. Any genitourinary or GI infection, if infection exists, excuse me. So any kind of procedure if there's already an infection that exists. So undergoing a colonoscopy, for example. Infected skin, muscle, bone. So the sort of the take home here is that if they're undergoing a procedure and they fall in this group here, the highest risk group, they should be giving antibiotics prophylactically to prevent and at least lower their risk of infectious endocarditis in the future. So my case question for you guys, 56-year-old man presents to the clinic with a high fever, dyspnea, edema, and productive cough for 2 weeks after a colonoscopy for a polyp removal. Physical exam reveals a new systolic murmur, heard best at the lower left sternal border. Chest X-ray reveals a lobar pneumonia. Echo shows regurgitation and a vegetation in one of the valves. Which valve is most likely affected? So a couple of things I just want to point out here. So really the question is just asking you, do you know what this murmur is, right? So a murmur heard best at the lower left sternal border. Okay, so that can kind of give you the clue right there, even without all the rest of this. Okay, but there's other clues in here I want you to make sure you guys kind of understand. So lower left sternal border, we're probably thinking tricuspid, and you would be right. And it's pretty much as simple as that. However, the other clues, all right, fever, shortness of breath, all right, edema, so this is pretty severe. Productive cough for 2 weeks after a colonoscopy. So there's a colonoscopy for a polyp removal. So that should start you thinking like what might be the species. So the question I could ask is, what type of bacterium might have caused this infectious endocarditis? And you might think something like strep bovis because that's the one that's most commonly associated with this. There's a new systolic murmur, right? So that tells you that's one of the major criteria for the Duke's criteria. All right. The chest X-ray reveals a lobar pneumonia. That tells you it's probably right-sided heart because it's probably a septic embolus that made its way to the lungs and caused an infection. And on echo shows the regurgitation and a vegetation on one of the valves. So I mean, a new murmur and vegetation seen on the echo really kind of meets two major Duke's criteria. So that could be another type of question I might ask. Okay, so now we're going to look at the outer layer. So we started with endocarditis, now we're going to look to pericarditis. So this will be the outermost layer. And if you remember, the pericardium has a visceral and parietal component. And in between those two layers is a small amount of fluid, somewhere just under 50 milliliters of fluid, which helps to kind of reduce friction in the heart. Now, this is going to be inflammation of this outer layer. And so most commonly, it's infectious. And the most common is going to be idiopathic or viral. And some of the ones that are most common for that are the Coxsackie virus group, influenza, mumps, HIV, just to name a few. And keep in mind, most of the idiopathic, meaning essentially we don't know, is probably going to be viral. And because virals, it runs its course, and by the time you actually test for, let's say, a viral panel, the person is usually already healed. And so it doesn't really help with the sort of treatment of it. So most of the time it's not done. So it's most likely, most of this is probably viral. TB or tuberculosis is another cause. Pyogenic bacteria, pneumococci, and staph. can cause sort of pus formation in and around surrounding the pericardium. The way in which the bacteria and usually invade the pericardium is usually from some sort of perforating trauma, like a stab wound or a car accident, surgical contamination, extension of a cardiac infection. So, for instance, infectious endocarditis can actually kind of move its way through the myocardium and ultimately seed the pericardium as well. So it can go the full length of all the layers. Extensions from other organs. So you can have a pneumonia that extends to the pericardium. Or it could have spread somewhere in the blood, right? So we call it hematogenous spread from a remote infection. Some non-infectious causes are actually following an MI. So usually within that first 24 hours or so, from a transmural infarct, that can cause irritation. Again, transmural because if it goes across the whole wall, that inflammatory response can irritate the pericardium. If it's weeks to months after an MI, it can cause something we call Dressler syndrome, which seems to be more of an autoimmune response to a lot of the antigens that got released from the myocardium when they were damaged. And that, again, the timing on that's important. It's usually weeks to months. Uremia is another very important cause. Again, this is going to be associated with the patients who have kidney failure, who are on dialysis, or some sort of chronic renal failure. And the urea itself, the high concentrations, can cause irritation and inflammation of the pericardium. Neoplastic causes, so you can get metastatic spread, like from the lung, breast, or lymphoma are the most common. And then local invasion, of course, if you have, say, a lung cancer or something of that nature, or even some cancer from the heart that has invaded into the pericardium. Radiation, typically due to radiation treatments for various cancers. Connective tissue diseases like lupus or rheumatoid arthritis, progressive systemic sclerosis are all causes, as well as drug-induced. So some of the most common would be procainamide and hydralazine have that sort of known risk. And you can see here cross-section through the heart there, and it's showing sort of highlighted region, kind of the pericardium here, which looks like whitish. All right, and that's actually a stiffening of the pericardium as it's sort of becoming calcified. It shows up sort of whitish from radiation treatment. And we're going to talk more about that, sort of the stiffening of the pericardial surface. Sort of the pathogenesis of pericarditis. This is really just basic inflammatory process. Okay, we kind of already know about this. If you have an injury, you get a local inflammatory process which causes vasodilation, which causes the fluids to move out of the capillaries and into that interstitial space there, and can cause sort of local swelling. And we call it a transudation because it's usually the more liquid portion, which that doesn't contain a lot of proteins or cells. The increased vascular permeability, all right, will actually allow white blood cells and proteins to make their way into that interstitial space there, and then it becomes more of an exudate. So the leukocyte exudation, as it makes its way across this more permeable surface, is sort of a double-edged sword. On one hand, it's necessary to fight and contain the damaging or growing bacterium, and at the same time, it's releasing a lot of mediators of inflammation that are very damaging to tissue as well. So hopefully, if it can be contained, it can actually get complete resolution, which you can see over here, just complete resolution, which would be nice. Sometimes, though, if it's an ongoing inflammatory process, it can ultimately lead to fibrosis and scarring, which you can see down here. And then lastly here, which is really just sort of this chronic, prolonged infectious process that ultimately causes damage and sometimes even loss of blood vessels and stiffening. To categorize some of the pericarditis, all right, we start with serous pericarditis. That's the exudate is thin fluid. All right, it's a very thin fluid. Typically, it's more of a transudate than anything else, where it's more fluid, doesn't have a whole lot of protein or cells in it. And this is characteristic of almost all early inflammatory responses in general. Serofibrinous means we have more fibrin, more protein. And so this is an exudate that contains proteins and portions of the pericardium and can thicken and fuse. So what you're having is an inflammatory process, and as it builds up, they can thicken so much they can actually fuse or rub against each other. Suppurative pericarditis, all right, this is intense inflammation. This is caused usually bacterial in nature, and it's pus-filled or purulent. And then hemorrhagic pericarditis is typical or typically more commonly found with TB and malignancy. Some of the clinical features of pericarditis, oftentimes they'll complain of what we call pleuritic chest pain, which means it's associated with their respiratory cycle. So it's usually worsened by breathing in. It gives them a sort of a sharp stabbing pain, which they can sometimes localize. Okay. And it's also positional, meaning that it's usually worse when they're recumbent or laying backwards, and it feels better when they lean forward. So it's a positional. Again, this is important to make sure we understand, because we want to make sure in any patient complaining of chest pain to be able to differentiate it from something like an MI. And these are definitely different from an MI type pain, where we can localize it. It's pleuritic in nature and positional. Also, it's an inflammatory process. It's usually associated with a fever. An MI can also be associated with a fever. And a pericardial friction rub. So again, if the inflammatory process causes thickening of the visceral and parietal pericardium, they can start to rub against each other. All right, and you can hear that, and you can hear it best when the patient is leaning forward. So as you see here, the patient's leaning forward. We're listening parasternally, and you can see they're really leaning forward over here. And so when they exhale, that helps to kind of bring the heart closer to the chest wall, and then you can really have them lean forward, and you can hear that rub. So it's very characteristic of pericarditis. Diagnostic studies of pericarditis. Well, on an ECG, some findings are somewhat characteristic for pericarditis. So, for example, you could see diffuse ST segment elevations. You can see some of these ST segment elevations here, right, on these leads. You'll see it over here. Basically, and a whole bunch of leads. You can see them over here. Here they are, right? So they're basically in all the leads. One of the important things to note about that, and this separates it from an MI ST elevation, is that in an MI, you usually have it associated with a particular coronary distribution, like 2, 3 and AVF, or V1 through V4, or V5, V6, 1 and AVL. Whereas here it would be in all the leads. And that's very uncommon for an MI. And again, this is probably caused because the inflammation of the pericardium is irritating the myocardial surface and causing damage to the myocytes. The PR segment depression is actually a more specific finding. And so if you look closely down here, these PR segments are depressed. So you can see that right there. You can see it over here. And over here, I've blown it up for you so you can see it right there. That's actually a very specific finding for it. You may not see it in all the leads, but it's something to keep an eye on, especially if you have suspicion of pericarditis. Lymphocytosis is a common finding. Elevated CRP and ESR. Yes, troponins will also be elevated. Again, that maybe make it tricky to thinking this is an MI, but in point of fact, again, if you see diffuse ST elevations and elevated troponins, think pericarditis. In an echo, that can evaluate an effusion. In other words, any kind of fluid that might be being released from this inflammatory process that could be building up in that layer between the visceral and parietal pericardium. Other tests to run, PPD for possible TB, right? ANA, RF to kind of look for any kind of other underlying possible causes like rheumatoid or lupus or something like that that might be causing this. Evaluation for malignancy, if it's suspected, right? Chest X-ray, mammography, CAT scans, and things like that to sort of figure out where the source may be coming from. Pericardiocentesis, so we're taking we're taking a needle and we're removing fluid from inside that space that surrounds the heart. And it's usually reserved for large effusions that are causing hemodynamic compromise, like a cardiac tamponade, right, which could compress the heart, which I'm going to talk about a little bit more a little bit later. The pericardiocentesis is useful in that it can relieve the pressure on the heart, as well as we can take that fluid and test it and culture it and to see if we can get sort of the underlying cause. Ultimately, though, for the treatment of pericarditis, if it's idiopathic or viral, is self-limited. Rest and pain relief with aspirin is usually helpful. And again, that's the most common cause. If it's MI related, rest, aspirin, treat the MI. Purulent, again, since that's more aggressive, that's probably going to require some sort of catheter drainage of the pus or purulent fluid. Antibiotic therapy, anti-TB therapy, etc., depending on what the agent is that's causing the problem. Uremia, again, kidney failure patients, they're uremic. If they're already on dialysis, you may have to increase their dialysis, but you'll basically be treating that kidney issue. If it's neoplastic, like metastatic, palliative care is unfortunately is really our only option. Is not as likely because we have a sort of reveals a mild effusion here. This person would probably have very high fevers and sort of a poor picture overall. So to treat this, we would want to probably increase their dialysis. Now, one of the complications of pericarditis can be an effusion. So we can have a buildup of fluid. And this is one spectrum of the problem, where we have a buildup of fluid that can ultimately lead to tamponade. So that would be so much fluid that essentially you're compressing all the chambers of the heart. On the other hand, we can have resorption of all the fluid, and the pericardium can become very stiff and almost bone-like. So I want to describe those two now. So we'll start with the effusion. Inflammatory exudates, so all that protein and cells and fluid that's building up in that area, right, is what we talked about. Another cause of the effusion could be non-inflammatory transudates, which are just more fluid with less protein, fewer cells. So for instance, things that can cause non-inflammatory transudates would be an increase in capillary permeability, like from hypothyroidism, increased capillary hydrostatic pressure, like congestive heart failure, or decreased oncotic pressure, like cirrhosis, nephrotic syndrome, where you're losing things like albumin, a protein that helps to maintain that pressure. Chylous effusion is a lymphatic obstruction and is most often associated with neoplastic or tuberculosis. Pericardial effusions, all right, there's a few things or a few factors that determine clinically silent versus signs of compression. And I'll kind of list them here in three: volume, rate, and compliance. And in fact, I highlighted rate because rate is probably the most important, the rate with which that fluid accumulates in that space. Now, generally speaking, the volume is less than 50 mils normally that surrounds that heart in that pericardial space. Now, you'll notice here in this graph, in A, this would be sort of, let's say, normal pericardium that has some compliance, which is number 3. So there's some compliance to that because as the heart expands, so too does the pericardial get stretched. Now, if it starts to fill up with a lot of fluid, up to, say, about 200 mLs, notice I put a little arrow here. You see that the pressure increases greatly after 200 mLs, which means the pericardial space can contain up to 200 mils with almost no change in pressure. But after that, any little bit more volume causes a drastic change in pressure, which again puts pressure on the heart and squeezes it and can cause compromise of the heart's function. Now, that's with the normal compliance in A. In B is the compliance of the pericardium of somebody who's had, say, chronically or slow filling effusion. And you'll notice that they can maintain a much higher volume because their body or their pericardium has had a chance to adapt to the increasing volumes. So because it can increase or it becomes more compliant, it's able to hold a larger volume without much of an increase in pressure. And this is almost double here. You see at 400 mils, you see there's an increase in pressures after that. And in point of fact, some of those volumes can actually get greater than a liter with almost no hemodynamic compromise. It all depends on the amount of time or the rate with which the fluid has been filling. If it's very slow, that gives a lot of time for the pericardium to adapt. If the rate is very fast, like suddenly having blood rushing in there because of a ruptured wall or some other kind of penetrating trauma, that can happen so quickly it can compromise the heart very, very fast. Other clinical features of pericardial effusion, chest pain, all right, findings of cardiac tamponade, which is basically increasing volume, causing compression of the heart, leading to signs that look like heart failure. Compression of adjacent structures. Again, this is going to cause the heart to kind of look like a balloon, and as it kind of balloons in the mediastinum there, it can compress local structures. Again, if it compresses the esophagus, it can cause dysphagia. Dyspnea, if it's compressing some of the lobes of the lung, causing some compression atelectasis. Hoarseness with the recurrent laryngeal nerve or the irritation of the phrenic nerve that's nearby can cause hiccups. And you can hear a muffled heart sound because you're hearing heart sounds within essentially what sounds like a water balloon. The chest x-ray is a useful diagnostic tool, but you're not really going to see the fluid unless it's greater than 250 milliliters. And the normal is usually less than 50 mils. So unless the fluid is greater than 250 mils, you can't really notice it on chest x-ray. You may just see an enlarging cardiac silhouette. On an ECG, you could have a reduced voltage because of a very large effusion can cause the voltages to be dampened. And you can also get an effect called electrical alternans when you have very large effusions like in the tamponade. So if you look at here, this echo. You can actually see the heart, and the heart is moving back and forth. Here's the apex of the heart as it swings back and forth, left to right. And this is actually the outer pericardial layer. And all this dark stuff here, this is all the effusion. And so the heart's actually free to beat and move inside that fluid. And when it does that, it can create what we call electrical alternans. In other words, if I were to have an electrode right here, all right, it's going to read it a very high, or say a greater amplitude when it's facing directly at it. And then when it swings away from it, it's going to give me a smaller reading. And that can alternate back and forth as the heart swings back and forth. In echocardiography, I can quantify the effusion. Anything greater than 20 mils can be quantified. I can see any kind of cardiac compromise if it's really squishing the chambers. And it also helps guide the placement of a needle in pericardiocentesis if I need to remove fluid. So here's an example of electrical alternans. As you can see here, as it alternates one to the next, the amplitude changes back and forth, back and forth. And that can be indicative of a very large pericardial effusion. So the treatment for pericardial effusion, if the cause is known, obviously you're going to treat the underlying cause. So, for example, dialysis for uremic effusion, treat the hypothyroidism or the congestive heart failure, and so on. If the effusion is asymptomatic, and even if it's very large, just serial examinations, follow up with the patient, right? You're basically monitoring to make sure there's no hemodynamic compromise, and in some cases it may even resorb on its own. If there is symptoms and or there's hemodynamic compromise, then that does indicate that is an indication for pericardiocentesis. Where you'll see over here, you can guide the needle in underneath the sternum there, and ultimately draw out the fluid, which is therapeutic, even though it may only be temporizing, a temporizing measure, because you remove the fluid, it could build right back up again. However, it may cause some relief of the symptoms at that time, may relieve the hemodynamic compromise. And then we can send that fluid off to be tested and then get the diagnosis and then treat the underlying cause, which brings us back to the first point. If the effusion is large, though, we call this a cardiac tamponade. And again, that's the opposite end of the spectrum from these asymptomatic pericardial effusions, because this is a high enough pressure to compress the cardiac chambers. I mean, you can see in the cartoon here, the heart's being compressed, and here's the pericardium on the outside. It's being compressed, and it's causing the chambers to increase in pressure inside the heart because they're being squeezed from the outside, which means that all through diastole, when the heart's supposed to be filling with blood, it can't really fill up at all because it's being squished. So you can actually see here that the veins, which are trying to empty into the heart, can't because they're being compressed by all this fluid. And since the heart's not filling up with fluid, it really can't add much blood to the arteries. And so you get somebody who becomes hypotensive because that lack of blood, the cardiac output goes down. You get distended veins, right, because it can't get into the heart. And the heart sounds very muffled because you get all this compression. In fact, that's the Beck's triad there. Muffled heart sounds, hypotension, and distended veins, JVD, would be our what we call a Beck's triad for cardiac tamponade. Many things can cause it. Any etiology of acute pericarditis can ultimately lead to tamponade, which is why pericarditis has to be taken very seriously. Most common are neoplastic, post-viral, and uremic. Causes of hemorrhagic tamponade are usually any kind of blunt or penetrating chest trauma, or a left ventricular rupture following a myocardial infarction. And finally, complications of a dissecting aortic aneurysm. Again, remember those type A aortic aneurysms that can actually work backwards towards the heart and cause a tamponade. The pathophysiology of tamponade is basically that you have so much fluid building up in the pericardial space surrounding the heart that it compresses all the chambers of the heart equally, and the pressures that accumulate in the pericardial space translate into the inside of the heart chambers. And so the heart chambers diastolic pressures go up. Because those diastolic pressures go up, it makes it very difficult to fill the heart with blood, and cardiac output starts to drop because it loses its stroke volume. Now, the venous pressures also rise, and that's because it can't empty the blood into this heart or into those chambers that are full of very high pressure. So that'll trigger a compensatory mechanism, an increase in heart rate, as well as an increase in contractility to try to compensate for that drop in cardiac output. And again, failure to evacuate the effusion can lead to ultimately shock and death, because as the heart gets compressed more and more, the cardiac output drops further and further, and this ultimately leads to death of organs and ultimately the heart. Over here in the picture, what you're seeing is pressure tracing from inside the veins, the jugular veins. So as you look this here in the normal patient, you see a rise all the way up to here, point A. That rise in pressure to point A is actually contraction of the right atrium. Then after it contracts to empty that last bit of blood into the right ventricle, right, the tricuspid is closed, and you see that you get this drop in pressure and then a passive filling as the it starts to kind of fill into the atria there. And then here in V, when the tricuspid valve opens again, normally what happens is the tricuspid opens, there's this passive drop in pressure as blood empties into the right ventricle, which this ultimately leads again to A, which is the contraction at the end of diastole. And that's our normal pattern. In tamponade, however, what happens is you can kind of see what looks like our normal A, contraction here of the atria, a drop in pressure after contraction, passive filling, and then the tricuspid valve opens again here. But when it opens, if there's increased pressures due to the fact that there's fluid surrounding the heart and pushing in on these chambers, what ends up happening is the blood that filled into the right atrium, as it tries to empty into the right ventricle, as it would up here, when you saw with Y, it kind of empties passively. Well, this right ventricle is not relaxed. The diastolic pressure is much higher due to that external compression. And so the pressure remains higher. You see that we have sort of what we call a blunted descent here, as it's trying to empty into a much higher pressure chamber. And so that, again, limits the filling of the blood into the right side of the heart, which causes it to back up into the veins, creating distension. So some of the clinical features I've already mentioned here, right? So here's Beck's triad. You can see the venous distension, the muffled heart sounds, and the decrease in arterial blood pressure. So that'll be your triad. Other things, sinus tach, which we talked about, pulsus paradoxus. Pulsus paradoxus is a typical thing that you can see, normal physiological sign of when you inspire. There's usually a small drop in your pulse pressure, or even a small drop in your blood pressure, usually less than 10 millimeters of mercury. However, due to the fact that the heart's being compressed, as you inhale, the same drop occurs, only it is a much greater drop. So instead of less than 10 millimeters of mercury, it's usually greater than 10 millimeters of mercury, and we call that pulsus paradoxus. Dyspnea and tachypnea, as things are kind of backed up into the lungs. Fatigue because of poor cardiac output, and edema, of course, for the same reasons as dyspnea. Acute Profound hypotension is common. Confusion, agitation, again, sort of relating to that drop in cardiac output. Diagnostic studies for cardiac tamponade include echo, again, to kind of look at the compression of the chambers and the amount of fluid that's accumulated. Cardiac catheterization is definitive because it can show you that there's increased intrapericardial pressures and increased intracardiac pressures, and the pressures are equal in all chambers during diastole, which is uncommon. And then pericardiocentesis ultimately to remove a lot of the fluids compressing the heart and to help relieve that hemodynamic compromise. In terms of pericardiocentesis, right, we're going to measure the fluid pressure. Fluid is going to become stained in culture. We're going to do a cytological examination to test for any kind of malignant cells, cell counts and proteins and lactate dehydrogenase levels to see if this is a transitate versus an exudate, because an exudate would signify more of an inflammatory process. You could also test it with adenosine deaminase for TB. And ultimately, in some cases, if it's recurrent, surgery would be warranted. And in those cases, sometimes they'll either put in like what they call a window, where they open up a section of it to relieve the pressure, or they'd actually remove the entire pericardium itself. And here you can see in this pediatric example, you can see the outline of the heart. All right, it's quite ballooned out. And after pericardiocentesis, you can see the actual size of the heart there. It makes it look like it's a giant heart, but in point of fact, it's really the fluid inside that pericardial space. So here, just asking you to see if you can figure out which ECG is consistent with a large pericardial effusion like a tamponade. That would be here, B. And you can see the electrical alternans as the heart can kind of swing back and forth inside that fluid sac, changing its electrical position. Whereas over here in A, this is diffuse ST elevations, and you can see some PR depressions. Sorry, I kind of went over it there. But you can see there that there's more of a specific finding for pericarditis. So now the opposite spectrum is actually, instead of filling up with a lot of fluid, is become constricted, where it loses. So this is a rare finding. TB is a common cause, so is the idiopathic or viral causes, as well as radiation therapy. So typically what happens is the pericardial effusion undergoes what we call resorption. So it gets taken back up. The lymphatics help with that drainage and so on. It helps remove a lot of that fluid. The fluid, though, can undergo what we call organization, and it can become what they say loculated, and with fusion of the pericardial layers. So different parts of the pericardium can become kind of fused to each other. It can form a fibrous scar, and again, this can also calcify. And if it calcifies, that can basically create a very rigid wall, almost like a skull. So this, all in all, is going to look very much like a tamponade type picture because it has very similar features. That rigid wall of the pericardium does not allow the heart to expand to its maximum. And so therefore it limits its ability to fill up with volume, and so it affects diastole. But the biggest difference, or one of the biggest differences here, is that in tamponade, it's affecting diastole both early and late diastole. So it's compressing the chambers at all times. But in this case, it's a constrictive pericarditis where the wall is rigid. It usually fills up with blood initially okay and very rapidly in the early diastole, but in late diastole, as it's still filling up, it hits a rigid wall and stops. Now again, it's going to look clinically very similar to a tamponade, because if I can't fill up the heart with good volume, it's going to reduce the stroke volume. The patient's going to be hypotensive. Also, if I can't fill up the heart with volume, it backs up, and if it backs up, it's going to create things like JVD. So it's going to look very, very similar to that pathology. But the key here is that the chambers are inhibited from expansion because they hit a rigid wall, not because they're being compressed from the outside by a large volume of fluid. So systemic venous pressures will rise, and there'll be a drop in the cardiac output. And if you look at this pressure time graph here from right and left ventricles, you'll notice that right after systole in the ventricles, as they open up, they fill up very quickly. So early diastolic filling. And as it fills up early on, so that's why you see this sudden rise here, fills up very suddenly, and then it abruptly stops filling, which you see here as the plateau. So you see sort of drop, fills up, and then plateaus. And it plateaus because it hits the rigid wall and can no longer allow any more volume into the chamber, and it's sort of maximizes pressure there. And that plateau, or this sign here, is called a square root sign because it looks like a square root. So some of the clinical features are reduced cardiac output, so hypotension, elevated venous pressures. All right, so that's in line with what we saw with the tamponade. But some of the things that differentiate it is instead of a muffled heart sound, you'd hear an early diastolic knock because it hits the rigid wall as it's filling up, and it sounds like a knock. Pulsus paradoxus can occur. It's less frequent, but it can occur just like in tamponade. And more commonly, you would see a Kussmaul sign. Again, a Kussmaul sign you can see in tamponade as well, and you see it here in a constrictive pericarditis. And what that is the JVD that's been caused by the increased venous pressure. In normal, in people who do not have constrictive pericarditis or tamponade, normally when somebody breathes in, it lowers intracardiac pressures. It also lowers the pressures inside the chambers as they expand with the wall a little bit, which creates a little bit of a vacuum. That causes blood to drain from the veins into the right side of the heart. So usually venous volume drops during respiration. In a Kussmaul sign, though, what happens is there is no drop in venous blood volume when they're inspiring. And in some cases, it can even become more distended. And the reason is, if it's surrounded by a rigid wall, or the heart's surrounded by a rigid wall, as the thorax expands and decreases pressure, normally the blood should rush into the right side of the heart. However, the heart can't really expand with the rest of the thorax because the rigid wall isolates it. And since there's no drop in pressure on the right side of the heart, it doesn't act like a vacuum, and so therefore the volume doesn't really drop from it. Now, diagnostically, chest X-ray, you might be able to see it, especially if it's calcified. An echo will show small ventricular cavities and sort of abnormal diastolic filling. CT and MR are really good at looking at the anatomy, and so it can really pick out a pericardial constriction. And then catheter can confirm the diagnosis, checking pressures and whatnot, so they can see that the pressures have also equalized, in this case, in diastole, just as you would see in a tamponade. So the treatment for pericarditis, if it's severe, is typically surgical removal. If it's non-severe, it's really just more or less followed and watched. But if it becomes symptomatic or there's hemodynamic compromise, usually surgical removal is warranted. Here in the chest X-ray, you can actually see the white outline here of the pericardium. So the case question is, patient presents with chest pain, dyspnea, fatigue, and dependent edema. This patient had acute pericarditis 2 weeks prior. Physical exam is significant for jugular venous distension and hypotension. So we have venous distension and hypotension. You are an astute PA student and you realize her findings could be a sign of tamponade or constrictive pericarditis because these are findings common to both. Which of the following physical exam findings would be consistent with pericardial constriction? So a drop in venous distension on inspiration is actually physiologically normal. What I described to you earlier was Kussmaul's. This would be the opposite of a Kussmaul. But again, you can see Kussmaul in either case. So that doesn't help. Muffled heart sounds. Well, you'd fear that in tamponade, not in pericardial constriction, so it's not B. Pulsus paradoxus can be seen in both, even though it's more common in tamponade, so that doesn't help. And the last one, D, a diastolic knock on auscultation because it hits that rigid pericardial wall, so D would be the answer in this case. So the last topic I want to cover is infectious myocarditis. So now we're talking about that middle layer between the endocardium and the pericardium. It has primary and secondary causes. Primary would be things like viral, like the Coxsackie virus, or a post-viral immune response. Secondary cause would be secondary to medications or exposure to medical chemicals, inflammatory diseases, and then finally maybe a genetic cause for autoimmune myocarditis like giant cell. The clinical findings usually again is fever. This is an inflammatory process. And now keeping in mind that this is a myocarditis, so it's affecting the myocardial cells, the contractile components, which are also in close association with the conduction system. So you can see different kind of arrhythmias. You can see signs of heart failure as the heart muscles become weakened or damaged. It can also look like an MI because it can release troponins. And this can cause things like tachycardia, gallop rhythms like an S3 or an S4, shortness of breath, again, sort of related to that heart failure picture as things start to back up and the heart fails as a pump. Ultimately, this can cause pleuritic chest pain if it starts to expand into the pericardial and pleural spaces there, and so they can end up with pain on inspiration. Now, I highlighted down here in yellow the fact that even though this may look like an MI, this would typically occur maybe in somebody who is younger, who doesn't have all the same risk factors that an elderly person with coronary artery disease might have. And so on examination, if they were to get, let's say, catheterization, they would present like an acute MI, but would have normal coronary arteries. So in other words, they would be clear, so that it would not be likely due to coronary artery disease, which is the most common cause. So that would be a big clue. The diagnostic studies of myocarditis: elevated troponins due to the damaged myocardium, elevated white blood cells since this is an inflammatory process. ECG would show ST segment abnormalities like an ST segment depression or elevation. Arrhythmias if it's affecting the conduction system. On an echo, you might see wall motion abnormalities. MRI, if an MRI were to be done, if you had suspicion of myocarditis, then if they use contrast like gadolinium, you might see spotted areas of injury all over the heart. And so that would also be a big clue, because if this were a true MI, most of those MIs would follow a coronary artery distribution and usually be to a specific region of the heart, whereas this would be more diffuse. A biopsy, again, if the suspicion is there, would confirm the diagnosis, and a biopsy would be warranted under these two conditions: heart failure with hemodynamic compromise, or a new arrhythmia with dilated left ventricle, 2 to 3 weeks after symptoms have started. So this will conclude this lecture. Please email me with any questions that you guys may have, and best of luck on the exam.